Alright everyone, so this is our video for the pectoral region and axilla, and once again these videos are being brought to you by the Scrubs team, which is the Student Collaborative Resources for Understanding and Brody Success. So going over our mission statement briefly, Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. So members of Scrubs participate in a variety of subcommittees that work to develop resources for students, by students, hopefully offering a perspective from students who have walked in your shoes and giving you some resources that we wish we had been exposed to during our time in the course. So hope is that this organization will become a staple of the Brody student body and exemplify the unique collaborative community that Brody offers. If this is a mission that aligns with your goals and you have a desire to help and give back to those that will come behind you, we would love to have you on the team. And quick disclaimer, these resources are indeed made by students and not by faculty. So as such, there is the possibility for errors, although we do try to mitigate this via a team approach and going through a couple of different stages of vetting. If there is at any point a contradiction within these videos and your coursework, please go by your course materials. Additionally, Scrubs is only a supplemental resource and it is no way replacing your instruction by the Brody faculty or your other course materials. Again, we cannot include all of the information that you are being given in the class in these videos, so remember that your primary course documents are the way to go when it comes to studying for this course. Now, getting into the actual material here, we're going to start by defining the pectoral region. So the pectoral region is the region of the anterior chest, and it's going to be bounded superiorly by the clavicle. So the clavicle is the superior border of the pectoral region. And on a slight tangent, I do want to note, anytime that you are giving borders in your course pack, it is going to be very important for the exam. One of the things that is very commonly tested are the borders of different regions. So once again, anytime you're given a border, you need to make sure that you mark that down because it is commonly tested on exams and quizzes. So once again, we have the superior border of the axilla is going to be the clavicle. You are bounded medially by the bone right in the middle, which is the sternum, and then the inferolateral border is going to be the ribs and the costal cartilages. Now, in total, there's going to be 4 muscles that we're going to talk about that overlie and originate in the pectoral region, and all of these are going to be associated with the upper limb movements, so they're not going to be considered intrinsic muscles of the thoracic wall. Okay, now talking about the breast. The breast is the most prominent region of the anterior region of the pectoral region. Now, I want to point out that in the breasts are being suspended by the suspensory ligaments. This is going to be a really important thing when we come to one of our clinical correlations at the end. Now, in males, the nipple corresponds to the 4th intercostal space. The intercostal spaces are the spaces between the ribs. So that 4th intercostal space is going to be corresponding to the male nipple, but only in males. The reason that it doesn't correspond in females is because in female breast, there is a little bit more fat tissue, so the region of the nipple line is a little bit more variable. It can be a little bit higher, a little bit lower, and it's not always a good indicator of the 4th intercostal space. So, one more time, the male nipple corresponds to the 4th intercostal space. That is a common thing to be asked on a quiz. Okay, now going over some more things with the breast. When we're defining the breast, in females, we talk about the breast originates from the 2nd rib and goes down to the 6th rib. Now, when you get into lab, you'll have to go through a model and you'll identify the lactiferous ducts, the lactiferous sinuses, and the areola, but we're going to skip out on those for right this minute for the sake of time. Now, I do want to point out the arterial supply to the pectoral region. In the breast, specifically, we're talking here about the lateral thoracic artery, internal thoracic artery, and the pectoral branch of the thoracoacromial trunk. Now, we're going to cover the vascular supply of the axilla a little bit more later in this video, actually in a lot more detail, so I'm not going to speak on it too much here, but what I want to point out is that the arterial supply to the breast is from the lateral thoracic artery. So lateral thorax makes sense because our breasts sit on our thorax. The internal thoracic artery, and it's going to be branches of our internal thoracic artery. And then there is going to be a pectoral branch of our thoracoacromial trunk. So the pectoral branch of the thoracoacromial trunk supplying additional regions of the breast. Now, actually getting into the pectoral region and the muscles. So when you're starting to think about muscles, it's really important for every muscle that you understand its origin, its insertion, its action, and its innervation. So those are the things that I have labeled here. Some people like to include the arterial supply. I often don't include this here because arterial supply is often by region as opposed to specific muscles, unlike what nerves are. So that's why I include nerves but not the vascular supply. So starting with the pectoralis major muscle. The pectoralis major muscle is located right at the front of the pectoral region. Now, it originates from the middle third of the clavicle, so here, the sternum, and ribs 2 through 6. Its insertion is going to be into the lateral lip of the intertubercular groove. Okay, and the main actions of the pectoralis major muscle are going to be adduction of the arm, or the shoulder, medial rotation, flexion, and extension. Now, when we're talking about flexion, we're mostly talking about the clavicular head. So it's important to note that the pectoralis major muscle has two different muscular heads. The clavicular head attaches to the clavicle, or that's its origin, and then the sternocostal head is originating from the sternum and the ribs. So that is the difference between the clavicular head and the sternocostal head. So one more time, that clavicular head is going to help with the flexion of the arm or at the shoulder joint, and then you're going to have the sternocostal muscle. The sternocostal head of the pectoralis major muscle is going to help with that extension at the shoulder joint. Now, the innervation for the pectoralis major muscle is going to be the lateral and medial pectoral nerves. And so what I've done here is I've included the spinal segments that correspond to these nerves. So the lateral pectoral nerve is C5 through C7. The medial pectoral nerve is C8 through T1. As you're beginning to study this material, spinal segments are going to be very, very important when it comes to the lab practical and when it comes to the computer exam. So anytime that you start to see these spinal segments, I would mark those down because those are things that often come up as second order questions on the practical, and they're definitely important for the exam. But don't stress about it too much at this point. This is going to become much more important when you start to learn about the brachial plexus. So wait until the brachial plexus to really start driving into these, but eventually you're going to want to really have honed in on the spinal segments that correspond to the nerves that innervate specific muscles. So that takes us to the pectoralis minor. The pectoralis minor muscle is located deep to the pectoralis major muscle. So deep to the pectoralis major muscle. It is going to originate from ribs 3 through 5 and is going to insert into the coracoid process. That coracoid process, remember, is a process off of the scapula. So I do recommend, if you're having trouble with the osteology, go back and review your bones because when you're learning muscles, oftentimes you are just given an origin and insertion, and if you're unsure of what those locations correspond to on the actual bones, the muscles can be quite difficult to learn. So one more time, originating from ribs 3 through 5, inserting onto the coracoid process of the scapula. One of the main actions of the pectoralis minor muscle is to stabilize the scapula by pulling that coracoid process anteriorly. Now, the innervation to the pectoralis major muscle is going to be the medial pectoral nerve. And once again, this is spinal segment C8 through T1. Now, I want to point out, the pectoralis major muscle was innervated by both the lateral and medial pectoral nerve, whereas the pectoralis minor muscle was innervated by just the medial pectoral nerve. You're going to see why this is important in the next slide. Now, going over the last two muscles of the pectoral region, we're going to talk about the subclavius. The subclavius is going to originate from the first rib, and it is going to insert onto the clavicle. And what this is going to do is when you have contraction, so the insertion point is going to be pulled towards the origin, you are going to have the acromion pulling anteriorly. So that's the main function of the subclavius muscle. Now, the subclavius muscle is going to be innervated by the nerve to the subclavius. It's really awesome that this nerve has a muscle name in it. So nerve to subclavius is innervating the subclavian nerve, or subclavius. Sorry. The nerve to subclavius is spinal segment C5 and C6. So C5 and C6 make up the nerve to subclavius, and that is going to innervate the subclavius muscle. Right, and lastly, the last muscle of the pectoral region is going to be the serratus anterior. The serratus anterior, just similar to the serratus posterior, is originating from the ribs. So the origin here is ribs 1 through 8, and then you are going to insert, and this is really important, your insertion is into the anterior medial border of the scapula. What does that mean to be inserting into the anterior medial border of the scapula? Well, this is the anterior border of the scapula here. So if you're looking from an anterior-posterior view, the anterior region of the scapula is the first thing you're going to see. Now, where is the medial border of the scapula? Well, the medial border of the scapula is right here. So that means that the serratus anterior is coming from the ribs, wrapping around and inserting right here into the medial anterior border of the scapula. This is a really common question to be asked, so that's why I've pointed it out here. But remember, the insertion of the serratus anterior is the anterior medial border of the scapula. The main action of the serratus anterior is going to be to protract the scapula. And then this is the nerve that innervates the serratus anterior is the long thoracic nerve. Please remember that the serratus anterior is innervated by the long thoracic nerve. This is going to have a pretty important clinical correlation towards the end. So the long thoracic nerve innervates the serratus anterior. Whose main action is to protract the scapula, and that is spinal segments C5 through C7. Now, here is a little bit of a cadaveric image of what we were just talking about. I'm going to try to start scattering these in as we go, but I'm not going to focus on this too much because I do recognize that you'll be seeing this again in lab. So really quickly with identification, here is your pectoralis major muscle. Up here you would have a little bit of your subclavius. It's a little bit hard to see under the clavicle here. Underneath this pectoralis major muscle, you would have the pec minor. And then over here you have your serratus anterior muscle. So what I really wanted to point out here is when we take the pectoralis major and reflect it, meaning we flip it over, so now we can see the pectoralis minor underneath, we can see two nerves. One nerve is going through the pectoralis minor and then hitting the pectoralis major. The other nerve is not hitting the pec minor, so you can see it's missing the pec minor muscle, which is here. So this nerve misses the pec minor and just goes into the pec major. So the two different nerves we have here are the lateral pectoral nerve and the medial pectoral nerve. If you think back to our previous slide, we said the medial pectoral nerve, which is C8 and T1 spinal segments, is innervating both the pectoralis minor as well as a portion of the pectoralis major. The lateral pectoral nerve, on the other hand, the spinal segment C5 through C7, is only innervating the pectoralis major muscle and not the pectoralis minor muscle. This is a very, very, very common view for a question on the lab exam. Very often you will see reflection of the pectoralis major, and then one of these two nerves will be tagged. And you will have to understand that the medial pectoral nerve is innervating both the pec minor and pec major, or the lateral pectoral nerve is just innervating the pectoralis major. That is how you would distinguish these two nerves on the lab exam. Okay. Now, getting into the axilla is a little bit complicated in terms of 3D understanding. And your course pack, again, is giving you some borders. So anytime you get some borders, this is going to be important because this is where you're often going to get some questions. So what you really need to understand is the axilla is talking about the region of the armpit. And the axilla is roughly going to form this pyramidal shape that we see here. So going through the different borders of your axilla, as your course pack describes it, we're going to start with the anterior border. The anterior border of your axilla, so up here in the front, is going to be made up of the subclavius, the pectoralis major, and the pectoralis minor. That makes sense if we think about the armpit and the region that we're in. Everything in the front up here is going to be pec major, minor, and subclavius. The posterior wall, so the thing that we see when we go posteriorly, is going to be the scapula, so the bone, and the subscapularis muscle. We are also, if we go a little bit further down, going to see the teres minor, teres minor, and the latissimus dorsi, which is actually better seen on this image on the right. Now, the lateral wall is going to be formed by the intertubercular groove of the humerus. So think as I bring my arm down, over here the lateral wall is going to be formed by the humerus itself. The medial wall, however, is going to be formed by the thoracic wall and the serratus anterior. Remember that the serratus anterior is originating from these ribs, so it makes sense that that would help to form the medial wall of the axilla. Lastly, or the last two things we want to talk about is the base of the axilla and the apex of the axilla. The base of the axilla is going to be formed by the skin and the fat of the armpit. So the skin and the fat of the armpit here is going to be forming the base of the axilla. The apex, however, is an open space that is going to be bounded by a couple of bones. So the apex is going to be bounded by the clavicle the scapula, and the first rib. So it's this open space right here. Here is your clavicle, here is your first rib, and in the back you have the scapula. So those are the borders of the apex. And in total, that will walk you through all of the regions of the axilla. The last two things that I want to point out are the anterior axillary fold and the posterior axillary fold. The anterior axillary fold is going to be formed by your pectoralis major. So this is the lateral border of the pectoralis major. You can actually, if you put your hand towards your armpit, this is going to be what you're feeling anteriorly. So that anterior axillary fold formed by the pectoralis major muscle. Your posterior axillary fold, so again, if you put your hand into your armpit and push backwards, you are going to be hitting the teres minor as well as the latissimus dorsi. So that is going to be what forms your posterior axillary fold. Now, really briefly going through the components of the axilla, you are going to have your brachial plexus, which is a quite dense subject and we will cover in an entirely separate video, your axillary artery and axillary vein, as well as lymphatics in the axillary region, which we will cover separately. So now what I want to start off with is covering the axillary artery, which can be pretty complex in itself, but is definitely very high yield for the lab practicals as well as your computer exams. So here is the axillary artery. What we've done here is we've removed everything else that could be a distractor, so we're just focused on the artery itself. Now what I want to point out is the axillary artery, for descriptive purposes, is broken down into 3 different sections. And you can see that that's labeled here 1, 2, and 3. So the first, second, and third portions are based on their relative relationship to the pectoralis minor. So remember, the pec minor is originating from the ribs, and it's inserting into the coracoid process here. So if it's originating from the ribs and inserting into the coracoid process, it is going to pass over top of your axillary artery. So the first region of your axillary artery is before the pectoralis minor is passing over top. The second region of your axillary artery is underneath the pectoralis minor muscle, as the pectoralis minor muscle passes over top of your axillary artery. This third region is the region after you go past the pectoralis minor muscle. So region number 2 is underneath the pectoralis minor muscle. Region 1 is proximal to the muscle. Region 3 is distal to the muscle. So those are the 3 different regions for the axillary artery. Now, I really like that the regions are named 1, 2, and 3 because what is important to know is that the vessels that you need to know, the named vessels that come off each one, there is going to be 1 vessel that you need to know coming off the first section, 2 vessels that you need to know coming off the second section, and 3 vessels that you need to know coming off the third section. So this just helps me remember how many vessels it is that I need to keep track of in each section. So talking about the first segment of the axillary artery. The first segment of the axillary artery gives off the superior thoracic artery. So the first branch of your axillary artery coming off the first segment is going to be the superior thoracic artery, and it is doing the superior thorax. So that is the superior thoracic artery. As I continue down the axillary artery, the next branch that is going to be giving off is the thoracoacromial trunk. So the thoracoacromial trunk is a singular vessel that is then going to split into 4 additional vessels. So this is 1 trunk splitting into 4 different vessels. The 4 vessels that the thoracoacromial trunk gives rise to are your clavicular branch, acromial branch, deltoid branch, and pectoral branch. These are all named based off of where they go. So the clavicular branch is going towards the clavicle, acromial branch is going to the acromion, deltoid branch going to the deltoid muscle, which overlies the shoulder, and the pectoral branch is going to the pectoralis major and minor muscles. Okay, so the thoracoacromial trunk is the first branch of the second segment of your axillary artery. This is, again, the second segment is going to be underneath the pectoralis minor muscle. The next branch that comes off the second segment is going to be your lateral thoracic artery. So we had a superior thoracic artery coming off the first segment, and off the second segment we have the lateral thoracic artery. The lateral thoracic artery is going to run with the long thoracic nerve, which is innervating the serratus anterior muscle. So there goes your lateral thoracic artery, coming off the second segment of the axillary artery. Now our third segment of the axillary artery, which is distal to the pectoralis minor muscle, which is overlying the second segment of the axillary artery, is going to give off 3 major branches that we're going to need to know. The first branch is the subscapular artery. So the subscapular artery is located right here. That subscapular artery, as you go distally, is then going to bifurcate into two other arteries that you're going to need to know. So the subscapular artery comes off of the axillary artery. It will then bifurcate into the circumflex scapular artery and then the thoracodorsal artery. So the circumflex scapular artery and the thoracodorsal artery are both branches of your subscapular artery. The thoracodorsal artery is going to run towards your latissimus dorsi. Okay, and the circumflex scapular artery is going to run along the back of the scapula. But again, both of those are branches of your subscapular artery. So that was branch number 1 in the third segment of the axillary artery. Now going to your next two branches, you have the anterior circumflex humeral and the posterior circumflex humeral arteries. As the name suggests here, the circumflex humeral arteries are going to be wrapping around the humerus. So the region that wraps anteriorly is designated the anterior circumflex humeral, and the artery that wraps posteriorly is designated the posterior circumflex humeral artery. So that is a very brief overview of the vessels that come off of your axillary artery. Now, even briefer, talking about the axillary vein, all I want to point out here is that veins are draining towards the heart, so your flow is going more medially. So if we start laterally, you're going to have a basilic vein and then a brachial vein that are going to join together to form the axillary vein. So the axillary vein here. The axillary vein will also get contribution from your cephalic vein, which is located here. The cephalic vein drains into the axillary vein, and eventually the axillary vein is going to drain back up into the subclavian vein. Okay, so it goes basilic vein and brachial vein come together to form the axillary vein. The axillary vein is going to get contributions, including from the cephalic vein, and then it will eventually drain into the subclavian vein as it makes its way towards the heart. Now, something that I want you to remember from here on out. If you see lymphatics in the course pack, you are likely to get a question. Lymphatics are important, and not just in understanding the lymphatic drainage of an area, but also in many cases due to cancer, because oftentimes cancer will metastasize via the lymphatic drainage. Also, infection is going to follow a pathway of lymphatics in many cases. So anytime you see lymphatics, mark that down, because there are very few cases that lymphatics come up within the course pack, but almost always you can guarantee that you will see a question on lymphatics on assessments. Okay, so talking about the lymphatic drainage to the breast. So what I want to point out here is that there is a lymphatic plexus underneath the nipple, also known as the areola. So underneath the areola, you are going to have a subareolar plexus. So this is the lymphatic plexus underneath the areola. Now, so you also have a plexus that is going around the areola and around the breast tissue. This is going to be your circumareolar plexus. So underneath the nipple is your subareolar plexus, and then surrounding you have your circumareolar plexus. Your circumareolar plexus can even go and drain portions of the adjacent breast. Now, for the most part, the lymphatic drainage from your subareolar plexus and circumareolar plexus is going to drain up into the pectoral lymph nodes. So for the most part, 75% or so is going to drain into the pectoral nodes. But that is the majority is coming from the lateral breast tissue. The medial breast tissue, about 25% of your overall breast tissue, can drain into your parasternal nodes. Your parasternal nodes are located beside the sternum. That is how they get their name. So the parasternal nodes are located beside the sternum, and they can drain the medial aspect of the breast tissue. So overall, there are two major terminal drainage points. You have the pectoral nodes, which are going to drain the majority of the breast tissue, but primarily the lateral aspects. And then you have the parasternal lymph nodes, which are going to drain the medial aspects of your breast tissue. So that is a brief overview of the lymphatic drainage of the breast. Now, even more importantly is talking about the lymphatic drainage of your axilla. So what I want to point out here is, once again, remember that our axilla is shaped like a weird looking pyramid. So at every point of the axilla, there is going to be a specific region of lymph nodes. What we have is, most anteriorly, we have the pectoral lymph nodes. So the pectoral lymph nodes are located closest to the pectoralis major and minor muscles. Again, these are the same lymph nodes that are draining the breast tissue that we were just talking about. So that is the pectoral nodes. Now, on the arm, as we go distally, we are going to have the humeral lymph nodes. So that is located here. Remember that lateral portion of your axilla is going to be the humerus, so that is your humeral lymph nodes. This is going to be the first lymph node that is going to receive drainage from the arm. So if you have an infection in the arm and it is going up to the lymphatic tissue, the first lymph node that would be inflamed will be your humeral lymph node. Also, in the back of the axilla, you're going to have these subscapular nodes. The subscapular nodes are draining lymphatic drainage from the posterior thoracic wall as well as from the subscapular region. So the 3 points at the bottom, the pectoral nodes, the humeral nodes, and the subscapular nodes. All of these nodes are then going to drain into a central node. Okay, so what happened was you had the pectoral nodes receiving drainage from the pectoral region and the breast tissue, the humeral nodes receiving drainage from the arm, the subscapular nodes draining from the subscapular and posterior thoracic region, all then go to drain into these central nodes. Okay, so once you're in these central nodes, you have to have somewhere else to go. You can't just stop here. So from the central nodes, you will then go to an apical node. So we go from a central node to an apical node. Think about the apex of the axilla. So remember that was that open space that allows communication of the vessels. That is going to be the apical nodes. From the apical nodes, we are then going to drain into specific ducts, which will then drain into the venous system. So on the right side, that duct is going to be the right lymphatic duct. And on the left side of the body, that duct will just be called the thoracic duct. These ducts then drain into the venous angles, which will then drain into the venous circulation. This will be something that you will come back to in your second exam. The main point that you need to think about here is remembering the pathway of lymphatic flow up into the apical nodes, and then from there we'll revisit the rest as the course progresses. So going over to brief clinical correlations, the first clinical correlation we want to talk about is pewter-orange sign. So the pewter-orange sign is a sign that correlates to the possibility of breast carcinoma. So when you have breast carcinoma, there is the possibility that those suspensory ligaments become tightened. So as those suspensory ligaments tighten and shrink, it can cause this little patching of the skin of the breast tissue. So this is the pewter-orange sign, and it is caused by the suspensory ligaments contracting. And remember, those suspensory ligaments are helping to support the breast tissue, and therefore it can cause this the skin to look almost like an orange peel, which is where it gets its name. And this is an indication of a possible breast carcinoma. The last clinical correlation, and one that comes up over and over again throughout your studies in medical school, is going to be a winged scapula. So over here, this patient has a winged scapula on the right. This is due to damage of the long thoracic nerve. Remember that the long thoracic nerve, spinal sections C5 through C7, are innervating the serratus anterior muscle. So if you have damage to the long thoracic nerve, the serratus anterior muscle is not being innervated. If the serratus anterior muscle is not being innervated, you will get winged scapula on the affected side. So in this case, this patient's right long thoracic nerve is not correctly innervating his serratus anterior muscle, which inserts onto the medial anterior border of the scapula, and therefore he is having a winged scapular presentation. So again, winged scapula associated with the long thoracic nerve, spinal section C5 through C7, and that is due to innervation of the serratus anterior muscle being disrupted. And with that, that will bring a close to this video.